Thank you so much, Agnes. That was very illuminating, and I really think we have such a robust cardiobstetrics program. We're very fortunate at UPMC. Next up is Dr. Bill Katz, who's one of the directors of our Echo Lab, senior structural imager, who has taught us a lot locally and is about to teach you a lot with respect to referral for valvular heart disease, should we lower the threshold. Thank you, Bill.
Okay. All right. Thank you for the invitation. When I was putting together this talk, I came up with some things to think about. Is the natural history of valvular heart disease to inevitably worsen over time? Are there identifiable and modifiable risk factors that we should be thinking about? And ultimately, can interventions used for the asymptomatic patient change the course of the disease and either improve quality of life or prognosis? Here's the outline that I'm going to follow. A little bit about prevalence, evaluation staging, and a couple of cases. Valvular heart disease, as we know, increases with age. By the time you get into your 70s, it's about 15% of the population with moderate or severe aortic valve disease. And this carries prognostic implications, those with and without valve disease. With valve disease, lower mortality or higher mortality and morbidity. And why is this? Well, valvular heart disease leads to ventricular failure, pulmonary hypertension, atrial fibrillation. So I think besides just thinking about the valve, we need to be thinking about these other things and intervene before we get to these complications. What does aortic stenosis do? It's an afterload problem. We see a ventricle gets very thick with small cavity. This is from the Laplace relationship. And as Dr. Levinson showed us, once we get symptoms, prognosis gets worse. But you know what? This curve starts going down even before you get symptoms. And why is that? There's an asymptomatic stage, and we looked at velocities as a predictor. Even less than 4 meters on the right-hand side showed poor prognosis, but with valve replacement, we get back on the curve. Well, one thing about these lower velocity patients is we have to wonder, are they truly asymptomatic? Were their Doppler measurements actually done adequately? There's a entity we're all getting familiar with, low flow, low gradient AS. This wasn't really recognized based when these studies were presented. So maybe we should be thinking about an earlier threshold for treating, and I want to go a little bit into the role of imaging. I just popped up a little image of a strain for somebody with low flow, low gradient AS, and this strain was abnormal despite the patient being asymptomatic. What about volume overload? Well, we can use mitral regurg as a model, leads to LV dilatation, which in turn leads to left atrial enlargement, pulmonary hypertension. And if you wait too long, you're going to not get recovery of LV function if you do an intervention. So we have to be thinking earlier. What are the resources that we have? It starts with our primary care physicians, primary cardiologists, having expert imaging and imagers, ultimately a multidisciplinary heart team, and we have a lot of guidelines that can help us decide where to go. The guidelines are evidence-based, and one thing that I took away from preparation from this is that we always talk about GDMT. Well, in this, the M is not medical, although it includes that, it's the management. So GDMT is management. So what does this lead us to? Clinical evaluation, diagnosis, medical therapy, and procedural treatments, with the goal to improve symptoms and prolong survival, and trying to avoid irreversible LV dysfunction, pulmonary hypertension, and atrial fibrillation. So how do we evaluate the patients? Patients may present with symptoms, or they may have a heart murmur, or it may be a totally incidental finding on an non-invasive test. These patients to start off, should have a meticulous history and exam, EKG for heart rhythm, chest x-ray, and a comprehensive transthoracic echo. The echo should include, obviously, looking at the valve and being very accurate with your quantitation for the stenosis and severity, looking at the LV size and function, looking at things like volume index, stroke volume index, global longitudinal strain, associated abnormalities, LA size by volume index, not AP diameter, ascending aorta, PA pressures, other valves, and have the ability to compare to prior studies. The lab has to be a high-quality lab. Valvular heart disease can be staged into basically asymptomatic, A, B, and C, or symptomatic, stage D. The A basically is your mild, B, moderate disease, C, severe disease, but asymptomatic, and they break it down into C1 with normal LV function and C2 with abnormal LV function. Finally, D, symptomatic, and echo is our non-invasive way to follow these patients. And in the interest of time, every 6 months to every year. Other modalities that we have, TE, very important, especially now that we have 3D for valve imaging, CMR for a lot of the things that the echo does, but also look at the myocardium for fibrosis. Very importantly, stress testing can give us an objective measure of whether somebody's really symptomatic or not. So why do we do exercise testing? Again, to uncover whether somebody's symptomatic, and we look primarily at their exercise capacity, blood pressure response. These potentially are high-risk procedures, so they need to be very carefully done. And if you add echo to it, you can also look at the valve response to exercise, the ventricular response, the hemodynamics, and this may assist you in your management. So let's take a case here. 62-year-old woman with known MVP, last echo 4 years ago. She has some mild dyspnea on exertion, no other symptoms. She's sedentary, non-smoker. She has a little bit of ankle edema. Echo was done at the primary care office that said LV size and function normal, posterior MVP with mild to moderate MR, normal left atrial size by AP diameter, normal PA pressure. EKG, some PVCs. If you classified this mitral regurg, you'd say stage B. The PCP, though, was a little bit nervous and said, surgery may ultimately be required at some point. That is a possibility. But we want to have the experts on board before that is an emergent situation and with heart failure. Never want to say, I wish we looked into this more previously. So the patient was referred, and on presentation was hypertensive, on no meds, a little bit overweight, BMI 30, had a mid-systolic click and an increased P2, suggesting some pulmonary hypertension. The outside echo images were reviewed to make sure that it was interpreted correctly, and we didn't think it was. So now we had some questions. Was this patient really actually symptomatic? Maybe this MR is more severe than we think. What stage is she, B, C, or D? So we did a treadmill test, and she only went 4 minutes Bruce protocol, which is abnormal. She had dyspnea. Her baseline echo showed left atrial enlargement, pulmonary hypertension. Her exercise test, nothing that came from that to show ischemia. So now we're thinking maybe she's stage D, symptomatic with severe MR. We started some blood pressure medicines, and for primary MR, some other things you look at for staging is whether the left atrium's big, whether you have pulmonary hypertension. So we went on, did a TEE. She has a very severe posterior leaflet prolapse with severe regurgitation. This was done on blood pressure medications with quantitation, and we felt this was something that needed to be intervened on, so we sent her to Dr. Bonatti, who did a very nice mitral repair. So we have the guidelines, we have these flow diagrams. For this patient, she was stage D on the left-hand side, so she should go for mitral surgery. Or maybe you might argue, well, she was not medically managed, a little overweight, maybe she wasn't really that symptomatic from the valve. But even with that, this was a repairable valve. So the dotted line flow could also apply to her. So let me show you one other quick case. Patient, nursing student at Pitt, who had cardiac arrest, resuscitated with an AED. Her echo showed she has mitral valve prolapse, which she didn't know she had, with mitral annular disjunction. This is not an insignificant problem. Arrhythmic mitral valve prolapse and sudden death. What do we do about it? Well, we had this patient get an MRI that showed late gadolinium enhancement of her posterior base related to this mitral valve disease. How do you stage somebody like this? Where do they fit into the guidelines? They don't really. This is how this patient presented. She received an AICD and is now being followed in our heart team clinic. And also, there was just recently a law passed in Congress to support valvular heart disease research, and this comes from a congressman who lost his wife from sudden death. Okay. To finish up, some final words from Ben Franklin: an ounce of prevention is worth more than a pound of cure. So again, we got to be thinking earlier. And also, Thomas Edison said, the doctor of the future will give no medicines, but will assist in patients in the cure of the human frame and diet and the cause of prevention of disease. We probably don't hope this is true, otherwise we won't be here talking about all the things we're talking about. So in summary, our goals: intervene before ventricular failure, pulmonary hypertension, AFib. GDMT includes the management, not just medicines. We need to identify who's truly asymptomatic, and thank you for your attention.